Avadesh Oli, and this work has been done at AFMC. No financial interest or disclosures to make. Retinal vein occlusions are second to diabetic retinopathy as a retinal vascular cause of visual loss. It has significant effect on visual acuity. There is no known effective medical or surgical treatment available. In patients of retinal vein occlusion, anti-VEGFs are known to decrease the macular edema. So was the genesis of this research question that was way back in summers of 2009 when we tried to evaluate the efficacy of intravitreal bevacizumab in treating retinal venous occlusions. The design of the study was a prospective, non-randomized interventional study. Duration was 2009 June to June 2011, and we studied 100 patients of retinal vein occlusion. After approval from the Hospital Ethics Committee, we took informed written consent from the patients, and they all underwent a comprehensive ophthalmic evaluation, which included a fundus fluorescein angiography and a OCT with Stratus OCT machine. A physician review was also done for all the patients, and they underwent blood sugar estimation, lipid profile, and we did plasma homocysteine for them. So macular edema, which in the opinion of investigators required treatment, which was mainly visual acuity and central macular thickness, was included. There were certain exclusion criteria, systemic contraindications for anti-VEGF use like coronary artery disease or a recent heart attack, uncontrolled hypertension, and certain other ocular contraindications like diabetic retinopathy, media opacity, and also patients who have undergone laser or intravitreal injections for the same or any other pathology were also excluded from the study. So all these injections of anti-VEGF were given in strict aseptic precautions. Individual tuberculin syringes were made in the OT from a vial of bevacizumab, and under topical anesthesia with a 30-gauge needle, the drug was injected into the vitreous cavity. And after the procedure, the eye was patched with the antibiotic drops, and patient was requested for a follow-up next day, and then after that the schedule was to come on follow-up at the end of first week, fourth week, and 4 weekly thereafter. At every visit when the patient came, he was assessed, his vision was recorded, and a OCT was done, and based on the vision and OCT criteria, repeat injections were planned. The outcome measures which we took were very objective. There were visual acuity as recorded on Snellen chart and central macular thickness on the OCT. For the purpose of statistical analysis, Snell's vision was converted to logMAR. We used SPSS version 17. Mean, SD, and range were presented for continuous parameters, and we used paired t-test, and a p-value less than 0.05 were considered significant. These were the results. The mean age of patient was 60.65 years, and 59% were males and 41% were the females. If you look at the type of retinal vein occlusion, in line with the results of the previous studies, almost 2/3 of vein occlusions were branch retinal vein, and rest 1/3, which was 31%, was CRVOs and 5% were HCRVOs. Well-known comorbidities also were the findings of our study, like diabetes and hypertension. But what came new was this homocysteine, which in Indian patients, in our study with 100 patients, it was 69, almost 64% of the patients had hyperhomocysteinemia. The mean level in these patients were 22.67, where we took a cutoff of 15 micromole per liter, and it was statistically significant. If you look at the visual acuity, the mean Snell's visual acuity at presentation was logMAR 1.21, which improved to logMAR 0.67. The mean difference was 0.56 with a SD of 0.46. These are the 95% confidence intervals, and with a paired t-test, it was statistically significant. 96% of the patients showed at least 2-line improvement over the follow-up. In the chart showing how there was gain in the vision after the injection. And these are some of the patients who after the injection had reduced CMT and corresponding improvement in the vision. CMT at presentation was 579, which reduced to almost half to 324, and it was also statistically significant. 98% of the patients, the CMT decreased almost 30%. And this is again the downward trend which is seen in the CMT post-injection. And these are some other patients who had, and this subgroup analysis we found when we compared young versus old, younger patients had higher CMT at presentation, but their vision recovery was much better. Similarly, when we divided these patients based on the homocysteine, we found that macular edema was severe in patients with hyperhomocystinemia, and when the injections were given within 3 months, the visual acuity was much better. Systemic complications were nil, other local complications were seen. This is in contrary to the recent CAT trial. So mainly DRPO are the most common. Hyperhomocystinemia was seen in almost 2/3 of the patient. In almost 96% patients, the vision improved. There was waxing waning of vision, but over a period of 6 to 8 months, the vision stabilized. To conclude, intravitreal bevacizumab improved vision, reduced macular edema, and it was a safe. We recommend study of combination therapy with laser or steroids to further reduce the number of injections. Thank you.